this week, and then the next time you guys have a lecture, we're going to be going over insurance, price setting, and price taking, and revenue cycle. And all of these are kind of linked together. So when you're preparing for the final, you kind of want to think of this class, and then the next set of lectures in a couple weeks, all kind of underneath the same little bubble um, within the course. So, just a little overview on insurance. So, we refer to insurers collectively as third party payers. And it's really important to understand insurance, even at a basic level, because and it's important. It's critical in terms of thinking about hospital and healthcare finance because insurance is the cornerstone of our reimbursement system in the United States. And our reimbursement system is directly a part of the operating revenue. In fact, um, the operating revenue is all reimbursements. The majority of hospitals in this country, see patients that have some sort of insurance, and if they don't, oftentimes they get very little reimbursed for them or paid for it. And just kind of a little bit of background about insurance. We actually haven't had a healthcare insurance system in our country for a very long time. It's really been around. Um, it started off around the turn of the 20th century, and in kind of its infancy, and there were various different types of insurance that covered losses if someone got injured at work, which was kind of the most popular. You would see someone chop their finger off while working in a mill, then there would be an organization that had insurance to cover that. But specifically, healthcare insurance, the first employee-sponsored hospitalization plan actually really dates back to the teachers union in Dallas, Texas in 1929. And what the teachers union did was they went to a hospital and they essentially prepaid this hospital for each person, each teacher that was part of the union. And interestingly enough, and the hospital said, okay, and what the hospital quickly realized that by taking this fixed payment for each teacher within the teachers union in Dallas, Texas, um, they had a steady stream of revenue, and it allowed them to better manage their hospital, better employ physicians, etc. And now on the other hand, the physicians were adamantly against this happening. They didn't like it. They thought that it would impact their ability to treat patients in a way, to collect the most amount of revenue. They were worried about that. But in reality, it gave hospitals like I said, a steady stream of revenue. Um, and then what we saw happen really to is the development of Blue Cross, which was the first private health insurance company in the United States, and that covered Blue Cross just covered hospital insurance, so they just provided coverage for hospital stays. And then there was an organization, Blue Shield, and Blue Shield covered um, the outpatient programs or healthcare, and they eventually merged and became Blue Cross Blue Shield. Interestingly enough, and we really started seeing health insurance in this country. And while I talk about the first plan being in 1929, based in Dallas, Texas, the reality is that health insurance didn't really become something that was picked up or popular until World War II. And during World War II, there was a lot of employment was high, but was a lot of wage controls, and so the government was putting, there were regulations regarding how much employees could earn um, because of the war occurring, and as a way to, to attract the best employees. Employers started adding benefits, and health insurance was one of them. And again, it was a way to compensate employees without breaking the wage limit rules that were in place. And what we quickly realized is once this trend started occurring, and once we developed a system where employee-sponsored health insurance is kind of the norm for people other than Medicare, it was really hard to go back from a employer sponsored program. And just to make sure we're all on the same page and definition wise, when I say employer sponsored or employee sponsored health insurance, this means that the employer pays for part of it, so people get their insurance plan through their employer, and their employer generally does the negotiating with the private insurers and so forth, and then offers plan options to employees, and then it's deducted from, the premium dollars are deducted from their monthly stipend. Just want to make sure everyone understands that. Let's just do a brief illustration on kind of the concept of insurance. And let's assume, just for simplicity's sake, that 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 you only face two medical outcomes in the coming year, and that is you either get sick, and the probability of that is 1% or 0.01. And if you get sick, it's going to cost you $50,000. And then the other option is that you stay healthy, and the probability that you're going to stay healthy is 0.99. And if you stay healthy, the cost of that is $0. It's nothing. And so we can calculate what is considered to be the expected cost. And this is the probability of outcome 1 times the cost of outcome 1, plus the probability of outcome 2 times the cost of outcome 2. And so when we do that math, it comes to an expected cost of $500. And what this does is it helps just give kind of what this does is it helps, explain that, we make decisions, and these decisions, regarding healthcare and the risks that are associated with our everyday life, and there are risks associated with that. And insurance is all about risk. It's about managing risk. And when we think about, this choice of, or the potential outcomes in a given year, either staying healthy or getting sick, everyone faces really the same medical outcomes and the same odds and costs associated with healthcare. And let's say that in addition to this expected cost that we've now calculated, let's say you make $60,000 a year. Now, with a salary of $60,000, you can easily afford the $500 expected medical cost, correct? That's not like that dramatic. The problem is that, no one's actual cost is going to be $500. If even though the expected cost is $500, the reality is that no one's actual cost will be $500. If you stay healthy, then your cost will be $0 for the year. If you get sick, your cost will be $50,000. And this amount could force you, as many people know who get sick know, into personal bankruptcy. Because if you make only $60,000 a year, a healthcare cost of $50,000 is really unmanageable. And so, let's suppose that you have a health insurance policy that pays for all of your healthcare costs in the given year, that is available, and it costs you $600. Would you take the policy? Would you take a policy that is slightly more than the quote expected cost, but it, is $100 more, um, but maybe gives you some peace of mind. And the reality is that most people would, and most people do. And this is because people are what we call risk averse. And that means that they're willing to pay a $100 premium over their expected benefits in order to eliminate the risk of financial ruin. So in order to eliminate the potential outcome that they could get sick and have a $50,000 cost, which would put them into bankruptcy, they're willing to pay a little bit more. They're willing to pay that $100 premium over the $500. So they're willing to pay $600 a year. Now, would an insurer be willing to offer the policy for $600 is the next question. And if the insurer could sell enough policies, it would know its revenues and costs with kind of a decent amount of precision. So, for example, if the insurer sold 100 million policies, it would collect $100,000 times 600, which equals 600 million. And, with and then with premiums, the payout would roughly be $100,000 times 500 equals 500 million in claims, and hence they'd earn about 100 million to cover administrative costs and provide a reserve in case claims were greater, in case there was they had more claims than what they predicted, and still make a profit. So essentially, for an insurance company, it makes sense if they can take on this financial risk as long as they can spread it out over a large number of people, over 1 million lives. And what this does by having a lot of people is it reduces the risk for the insurance company, and technically for each individual. So it's important to understand that there are 4 characteristics of insurance. And, I think that, this and the previous slide could very well be a test question. So if you're keeping track of those, of hints or clues, I could expect you to understand what the 4 characteristics of insurance are and be able to explain each of these. So the first characteristic is the pooling of losses. And what this means is that essentially there's a sharing or pooling of losses, and this is at the very heart of insurance. And what pooling means is that the losses are spread over a large group of individuals, so that each individual realizes the average loss of the pool rather than the actual loss. Now, essentially, in addition, pooling involves what it means is that you have to group a large number of what we consider homogeneous people or things into one group, and that through this you can again pool your losses. But this implies that that there's the sharing of losses by the entire group, and that the prediction of future losses with some accuracy is based on the law of numbers. Now, a lot of you are probably not familiar with that term, the law of numbers. But the best way to describe what the law of numbers is that essentially, you can't predict. What it says is that you can't predict, one individual, individual single event with confidence, but that you can prevent an aggregate of results in confidence. And so let's think about flipping a coin. Let's say you have a coin and you have and let's say you flip it 1,000 times, and you can pretty much with some accuracy predict that out of 1,000 flips, 500 of those flips you'll get a heads, and 500 of those flips you'll get a tails. So in other words, it implies that you can predict the number of outcomes, using an identical, what we call identical trails. And so again, it's just the concept that, if the coin is only flipped once, you don't know if you're going to get a heads or a tail. But if you flip it, multiple times, you can predict with some accuracy what you're going to get. And so just to make sure, the law of large numbers implies that predicting outcomes is easier when there are, many events or a lot of things occurring, versus one single individual event. The second characteristic of insurance is that it only pays for random losses. So insurance only pays for random losses. And the key word in here is random. So random means that it's unexpected, it's unforeseen, and it occurs as a result of complete chance. And so insurance is based on the premise that payments are made only for losses that are random. And we'll kind of talk about this a little bit more in the future, in some other slides, in terms of that randomness. Because I'm sure many of you are thinking about insurance and wondering how random some of the things that health insurance pays for. Going on to the next slide. Characteristic is that it's called risk transfer. And so an insurance plan almost always involves risk transfer. And the sole expectation of an element of risk transfer means that the risk is shifted from the insured to the insurer. So if you think back to the question when we calculated that, you can either get healthy or be sick in a year, and the chance that may happen, are you willing to take that chance? All of that those are risks, and what insurance does is it transfers the risk from the insured to the insurer, and essentially the insurer is in a better financial position to pay for the loss than the insured is due to the premiums they collect. And the fourth is called indemnification. So this means what the last characteristic of insurance is that the insurance company is going to reimburse the insured when losses are occurred. So when a random event happens, the insured has an event, the insurance company will reimburse them for this loss. Now, let's say, just as an example, kind of in summary, how we can apply these 4 characteristics of insurance. So for example, when you think about our example a couple of slides ago, the insurance is pooled across 1 million. The losses for the insurance is pooled across 1 million individuals. The losses of each individual is random and unpredictable. The risk of loss is passed to the insurance company, and the insurance company pays for any losses. So just to kind of put that into layman's terms. But, all of these are kind of economic concepts, these 4 characteristics of insurance. And the reality is that, people are people, and some other things kind of come into play. And we're going to get into that on this next. So it's important to understand this concept of adverse selection. And so one thing that kind of sometimes can get in the way of insurance or make insurance, difficult is this concept of adverse selection. And so what adverse selection says is that, is that those who are more likely to incur losses are more likely to buy insurance. And then this drives up the cost of insurance. So essentially, those of us that are more likely to get sick are going to go out and buy insurance. And if we're not likely to get sick, we're not going to go out and buy insurance. And, I think a good example of this, is the fact that many young people under the age of 25, don't think that they need insurance because they don't ever get sick. But, if someone, has either had a healthcare event in the past, they make sure that they're always insured because they're worried about getting sick. But how do we control for adverse selection? How do we make sure that, essentially, that the only people buying insurance are the ones that need to use it? Because then that means that, you won't have enough in the loss pool. But How do you make sure that we don't just have the really sick people buying it, or the people that are going to need a surgery? And the first is that we have what's called underwriting. And underwriting is a selection and classification of candidates for insurance. So, for example, um, in our country, we when individuals buy insurance, the insurance company is allowed to ask them if they smoke, and if you smoke, the insurance company is allowed to charge you more. So, for example, a lot of employers in the country actually do, make you sign an affidavit saying if you smoke or not, and if you smoke, you usually pay a higher, you can pay, $25 more a month, depending. I mean, I'm just giving that example. It may not be $25. It depends on the organization. Um, but, if the problem with adverse selection is because if the tendency toward adverse selection goes unchecked, then you have a disproportionate number of sick people, or those more likely to, to become sick, that will seek health insurance, and the insurance company ends up experiencing, a high number of claims, and that these claims trigger premium increases, and this just worsens the problem. And so, because healthier members of the plan and what this does is this causes healthier members in this plan to either pursue cheaper rates from another company if available, or they just decide not to be insured. So if you are someone who is sitting there and you don't use health insurance, you don't generally have to use your insurance. The only time you go to the doctor is for a physical every year. And which you could happily pay out of pocket and isn't that expensive. But you're paying a lot of money, and then you get a notice at the end of the year saying that for the next year your health insurance is going to go up, by 25%. You're going to be pretty frustrated, and they're potentially going to lose you, which is bad for the plan. And so the next way, in addition to underwriting, a lot of health insurance companies used to have pre-existing condition clauses. Now, most of the pre-existing condition clauses, have either been modified as a result of the Affordable Care Act, or they no longer exist. So, I believe the Affordable Care Act says that, you can no longer deny coverage for pre-existing condition. But what they do say is that, sometimes there's like insurance companies can still kind of have this like grace period where, you can't, if there's a pre-existing condition, you're not eligible for coverage for the first like 3 months of your acceptance into the insurance plan. So again, this is like one way that that health insurance is trying to ensure that they keep kind of a check on this adverse selection issue. Next concept that is extremely important to understand is the concept of moral hazard. And so what moral hazard, so just to back up, so remember that insurance is based on the premise that payments are made only for random losses that and that these random losses, again, it's all random, but the problem is that moral hazard says that that sometimes we consume more health care because individuals don't bear the full cost of the services provided. So let's actually take an example. So I always like to tell this story. So my father had this like face cream that he put on like, you know, once a month he had to add it, or maybe twice a month, every other week, once he had to add it to his face. And he had this little tube, and he would add it because sometimes his face would get like itchy. And he, under his normal health insurance policy, my mom would just, went and filled a little tube. And his doctor had written a bunch of um, a bunch of refills for this tube of medicine, this cream ointment. Well, my dad works and he drives 40 minutes to work, and he comes home after a couple months and he's like, gee, it would be really nice to have, that little tube, a tube just like I have at home, but have one for the office because, like if I get itchy, if my face starts to itch, I'd love to be able to put it on, right there instead of having to wait till I get home. So my mom goes out and fills a prescription and she brings it home to him. And, next thing you know, kind of fast forward a few months, my dad has one of these tubes in the car. He has one for his travel dop kit because my parents like to travel on weekends a lot. He has like 4 tubes of this medicine hanging around different places. And each of them are pretty full. Like he maybe uses it once a month, maybe takes from a single tube once a month. Um, well, then my parents got into a different healthcare plan, and he had a much higher deductible. And my dad, says to my mom, "Hey, can you go and fill this prescription? I just need a tube." And my mom calls him, and she's like, "Bill, do you really need this tube of medicine?" And my dad's like, "Well, yeah. What's the problem? Like, I want one for, I want one for, the other car that we drive. I want one in another place." And my mom says, "Well, I'm asking you because it's $550 and my parents hadn't met their deductible yet. So my dad was going to have to pay it." And my mom says, "Do you absolutely still want this medicine? It's $550. I'll get it if you need it, but it's really expensive." And my dad says, "Absolutely not. Do not buy it." And the point of that story, even though it was a little long, is that what Moral Hazard says is that, my dad was not prior to, joining that new health insurance plan, he was filling a prescription, because he really wasn't exposed to, he didn't know the true cost of it. For him, he was just paying a small, $15 copayment each time he picked it up um, each time he picked it up. But the reality is it was a really expensive medicine. I mean, that not everybody can, that's a really expensive medicine. But and essentially it means that he consumed more health care, bought more because he didn't know the true cost of it. And, I think this happens a lot. And so how do we deal with this in insurance? And, you want people to kind of be active members, and you want them to be exposed to healthcare costs, some ways, so that they're good consumers of it. But they also, you don't want them so exposed to costs that they feel like they can't, that they can't use it when they absolutely need it. So there's kind of a balance, but there are really, the following ways. First off, I just want to make sure I have included the definition for premiums because I want to make sure everyone understands what a premium is. But premium is the dollar amount that insurers pay to be covered under insurance policy, and it's usually paid on a monthly basis. So that's just what you pay just to be in the insurance plan. And then you have deductibles. And so this is a dollar amount that must be spent on healthcare services in a year before any benefits are paid by the insurer. So, for example, your deductible could be $1,000 a year. And, essentially what that means is that, every time you go to the doctor, you'll pay, the full price until you hit that $1,000. And then the benefits start being paid by the insurer. And, you kind of hear these stories nowadays that these deductibles are, at crazy amounts. And it's kind of interesting. And so what this does is this means that, you're going to really think about, if you need to go to the doctor, if you have not met your deductible yet, because you're going to have to pay that out of pocket. So the next thing that they do is they have a copayment, and this is a fixed cost, excuse me, to the patient each time a service is rendered. And what this, a lot of people pay like $15 or $30 every time they go to the primary care physician. And the idea is that by having some sort of coinsurance or, fixed amount that you pay every time you go, you will be sure that when you go to the doctor, you're not just throwing away $20 or $15, however much your copayment is. The next thing that insurers do to deal with this issue of moral hazard is they have coinsurance. And coinsurance refers to the sharing of costs between the patient and the insurer. So, for example, oftentimes what they'll say is after you have hit your deductible, the patient is still responsible for 20% of all costs related to a hospital care. And again, this is a way of keeping the patient exposed, but not, but still offering them some sort of coverage. The next thing that we're really seeing is what's called the high deductible health plan. And high deductible health plans is a type of health insurance that requires a high deductible. So, sometimes you'll see it as like a $5,000 deductible. But it allows individuals to set up what we call tax advantage savings accounts, which are called HSAs, health service accounts. And what this does is it says, it allows people to take out, dollars pre-tax, so they're not taxed on it, and they can put it into a healthcare, like a health savings account that is a bank account that can only be used for healthcare costs that are and things like visits to the doctor, tests, labs, if you need prescriptions and so forth. And then what ends up happening is that this account, if you don't use it at the end of the year, rolls over to the next year. So you can continue to build up this pre-tax savings account, which you're not taxed on at any point, and it continues to roll over until you have a healthcare event. So again, the concept is that, you have a pre-tax advantage, so you have a savings account that you can pay for with this stuff, but you're exposing people more to the healthcare costs so that you can kind of make sure that when they do consume healthcare, they actually need it, and you can kind of control for this moral hazard problem. So the next part of the lecture is I'm going to give an overview of of where we are as a country and the extent of the nature of coverage for employee-sponsored insurance, the individually purchased insurance, Medicare, Medicaid, and then kind of where we are with the uninsured. And I apologize, most of this data is back to 2011. It's really hard to get access to some of this data, and I just haven't gotten to get kind of like the next round of numbers. So where does this data come from? So there's really three main data sources. There's the Current Population Survey, which surveys 50,000 households, and it kind of does it in waves. Then you have the American Community Survey, which surveys 3 million households each year. And then you have the Employee Benefits Research Institute, which provides a lot of this data, in case you're curious. So this right here shows the number of Americans under the age of 65 in 2000 and 2011 by type of insurance. So, as you can see, the employee-sponsored health insurance covers, in 2011, about 58.4%, or 155.5 million people in this country. It is the most popular, or the most, not popular, I wouldn't say popular is the right term. I mean, it's the largest percentage of payers largest type of insurance in the United States. Um, and if you look at employee-sponsored health insurance coverage, so most of this it's obtained as part of a compensation package that workers receive, and usually it comes a few different options. You can have single coverage, so it's just you're the person that works at the company. The employee is the only person that's covered. Employees can cover themselves plus their spouse, or themselves plus plus their two children, or a child and then, or you can do family coverage, which would cover your spouse and your children. And approximately half of those with this coverage have it through their own employer. So, and then the rest are dependents. So a dependent is someone who is married to, or the child of, or a legal dependent of someone that works for a company that offers insurance. So, for example, during graduate school, my husband was working and his employer offered health insurance. He so he had the insurance through his employer, and I was the dependent on his plan. This shows the age distribution of employer-sponsored health insurance coverage in 2009. So if you look, um, you know, one of the problems is that, you know, you don't see like these huge, the bigger groups are definitely the older people in terms of the coverage. If you look at the 66.4 in the ages of 45 to 54, again, the 55 to 64, 64.5% of all of those people have insurance through employee-sponsored coverage. So this next graph shows the percentage of workers with employer-sponsored insurance coverage by industry. As you can see, the public sector had 85.6% of all workers in this sector have access to have employer-sponsored health insurance coverage. And then on the other side, in our agricultural industry, only 52.5% of the workers in that industry have employee-sponsored health insurance. So next, this is the percentage of firms offering, or companies offering health insurance by number of employees. And so number of employees is a big deal because the larger amount of employees you have, the greater ability you are to pool risk. And so 98% of all firms with 200 plus employees have health insurance, offer health insurance, versus if you go down to really small employers, the employers with 3 to 9 people in their firm, only 50% of them offer a health insurance policy, at least one health insurance policy. And as you can see, it goes up at the bigger the organization gets. So typically, employer coverage is generally offered to full-time workers, and only 20% of firms offer coverage to part-time workers. So 66% of those with greater than 5,000 workers, or 66% of those 28% have greater than 5,000 workers. Now, this is important because if you for some reason are considered part-time and you don't have a spouse, you don't have a significant other's plan that you can go under, how are you supposed to get health insurance? I think it's a huge deal. The next is that approximately 77% of workers are eligible for coverage when offered. However, of these, only 81% take the coverage. So, there are people out there who have, their employer offers health insurance coverage and they do not take it. And, the question is why? Is it that they're young and they don't think they need it? Is it that they would rather just deal with the cost themselves? Maybe their employer doesn't have a good plan. I think it poses a big question as to why, they don't value that, why they don't think that the deal offered through their employer is the best. Um, the next, let's talk about what kind of health plans are offered through employers. Um, so, of the the firms that have 5,000 employees or more, 25% offer um, three or more health plans, and 49% offer at least two plans. And this is important because, if you've ever been choosing healthcare, you want options. And if your employer only offers one health insurance plan or two, even two, you don't have a lot of offers. Now, of the firms that have less than 200 employees, only 17% offer more than one plan. Um, so again, what kind of choices do your employees have when they're trying to make decisions about what type of health insurance plan is best for them? So next, let's look at our premiums in the United States for employee-sponsored health insurance. On average, the 2012 monthly premium was $468 for a single coverage and $1,312 for family coverage. Now, employees make contributions to the premiums, which help reduce the premium cost exposed to the actual employee itself. But, they're not making huge contributions. So, of the $468 for single coverage, the average 2012 employee premium contribution was $79 for single coverage and $360 for family coverage. So, premium contributions have really been a constant percentage of the total premiums over the last decade. So, in the last decade, the single has gone from 16 to 18%, and the family has gone from 26 to 28%. Think about coverage. Not all insurance policies are the same. Some offer, some cover more, more, or some cover, some cover more um, types of services than others. For the most part, virtually all employer-sponsored insurance plans cover hospitalization, physician visits, prescription drugs, ambulatory, and inpatient mental health services. Um, Now, but the extent of coverage differs substantially. Now, they may not cover, all prescription drugs, or they may try to encourage you or only cover, some drugs that are, um, that don't have an off-brand name, at a certain percentage, or they only cover, hospital care in certain hospitals or within a certain network they create. Now, copays and deductibles are extremely common. So in 2012, 30% of HMO enrollees face a deductible, as do 60% with a point of service plan and 76% of a PPO. The average deductible ranged from $691 for an HMO to $1,014 for a point of service plan. And then less than 10% of covered workers do not have a copay for a primary care physician visit. So the majority of insurance plans require some sort of copay for PCP visits. And again, these plans differ because they're trying to change how, they're trying to encourage certain utilization patterns, and it really is based on the mix of patients um, within the the insurance plan and what they need to direct people to. When I say the insurance company needs to direct people to. So this is the percentage of insured workers in larger firms enrolled in plans using some sort of utilization management technique. Um, a utilization management technique is some way that the health insurance plan, tries to encourage you essentially to only utilize healthcare when you need it. So in 1997, 92% of larger firms, larger firm insurance plans, 92% had some sort of hospital pre-admission certification. So this meant that you had to call in to get admitted to the hospital, and that they would tell you if you were okay to be admitted. Basically, they wanted to ensure that only people that needed to were admitted. As you can see, as we've gone, up to 2007, this is less common. There's less pre-certification for hospital admissions with regard to these type of plans. Now, we're still seeing about 52 to 56% of all ambulatory surgical pre-certs are required within these plans. So that means that before you do some sort of before you have surgery, you need to call and get the approval for it. So, for example, I have a daughter who had tubes put in her ears, pretty common for kids. And before she could get the tubes put in, to ensure that it would get covered, I had to call the insurance company and submit a form, and then they, in a week called back and said, yes, we'll cover it. And so they do this in order to try to prevent, unnecessary utilization. Now we're still seeing a lot of high cost case management programs. So if you can see in 1997, 81% of these plans had these types of programs. It went up in 2005 and is now down to 82% in 2007, which is the latest number. And what a high cost case management program is so I am very familiar with these as they relate to cancer patients. So if you've ever known someone who is going through cancer treatment, oftentimes they will get a case management worker within their insurance company, and this person tries to direct the care to ensure that they will best utilize the parts of their insurance coverage that that will keep costs lower. So oftentimes this person, I think that from a consumer perspective, it feels like you have someone at the insurance company who is your one point in contact, and they know your case, they know they know what you're going through. You have their direct phone line versus having to go through a 1-800 program where someone doesn't know, kind of what's happening. And from the insurer's perspective, by having that one person who's in charge, who represents the insurance company during these cancer episodes, what it means is that they can again ensure that that people are utilizing healthcare in the appropriate way and reducing, keeping costs down. So let's talk about the high deductible health plans. There's still a lot of data coming out about these. They're becoming a lot more popular. So the Kaiser survey, or the HRET survey, said that in 2012, 31% of all firms were offering some sort of high deductible health plan, and the average single coverage deductible in an HSA eligible type plan, so in these high deductible health plans, for a single coverage, the deductible is $2,190. So that means that that an individual has to reach $2,190 of out-of-pocket costs before the high deductible plan will kick in the insurance coverage. So next, let's go to the individuals. So in 2011, 18.9 million people had individual health care insurance, and this equaled 7.1%. So this is not purchased through a group, and we're seeing it play a bigger and bigger role. In 2011, it did not play a big role, and the insurance exchanges through the Affordable Care Act are increasing are making this more and more we're seeing it more and more in the country in terms of the percentage of individuals covered through individual plans. Um, and this is also large in part due to the individual tax credits. A lot of these are consumer directed health plans. And, the thought was that perhaps we may be moving away from employee sponsored health insurance. I would not say we are. That's what people predicted would happen. I think that there's still there's a lot to have happen between us eliminating employee sponsored health insurance. Um, I think the downside to employee sponsored health insurance is that it ties your health care coverage to your job, and if you're not able to, if you're someone who switches your jobs frequently, or you need, you lose your job, then you lose your health insurance coverage. And so on this slide, this is a percentage of non-elderly, so people not eligible for Medicare with individual purchase health insurance. So as you can see, of the percentage of the population between 55 and 64, 10.6% have health insurance, have individually purchased health insurance. And it's pretty low among the younger populations, 6.5 or 6.7 to 6.5%. So the next, let's look at our Medicare. So in terms of the number of people with Medicare in our country, in 2011, 8.4 million people had Medicare, and this is 3.2% of the population. So this covers 8.4 million people under the age of 65, and this also covers Medicare disability and dependents of Medicare eligibles, and essentially all residents over 65, which is approximately 39 million people. And we have Part A, B, C, and D. A is the hospital, skilled nursing, and home health coverage. It's paid for by payroll taxes. B is the physician services and durable medical equipment, and it's paid for by the general taxes and monthly premiums of, so the monthly premiums of the people within coverage. C is a Medicare Advantage plan or Medicare Managed Care, and people usually have this. They have C if they don't have A and B. And this covers approximately 25% of all Medicare beneficiaries. And then you have Part D, which is the prescription drug coverage plan for Medicare, and this is voluntary, and it's paid for again through an additional Medicare, through an additional premium. So it's important to understand that the difference between how Part A is funded and how Part B is funded. By law, Part A is paid for through payroll taxes. So a percentage of the payroll taxes, the federal payroll taxes, go to fund Part A. And this means that by law, it gets funded every year, and you don't have to, it's there. The revenue is going to be there. Versus Part B is paid for by the general taxes and monthly premiums. So a small percentage is paid for through a monthly premium that that all the Medicare beneficiaries pay for, but then it's paid for through the general fund taxes. And what this means is that this is the general fund is what what the legislature approves through the budget. And so if they don't approve the money, or they're fighting over the budget, as this happens many times in our country, and they can't pass a budget, then they can't fund Medicare Part B, and so it's a big deal. So many many Medicare beneficiaries receive some sort of supplemental coverage. So 33% of all Medicare beneficiaries also have an employee-sponsored healthcare coverage. They have Medicare Advantage, so they've decided to do all of the programs. They have a plan called Medigap, which exactly that. It's another plan that you can buy that is supposed to, quote, cover the gap for what Medicare doesn't cover. We have our dual eligible, so the people who have Medicaid and Medicare, it's 15%. And then about 10% have no supplemental coverage. So let's look at our Medicaid population. So in 2011, 17.6% of the population had Medicaid, and this comes out to 46.9 percent. And these are under age 65, but 46.9% have Medicaid. Medicaid is a joint federal and state program, and the 17.6% is really probably an estimation of coverage. So it doesn't include the 65 people over the age of 65 who use it for nursing home coverage. And there is suspicion that CPS misses a number of Medicaid eligibles, that they don't really quantify their Medicaid eligibles. And some people have estimated that at about 5.8 million people. So here is the distribution of Medicaid enrollees and expenditures. And so the yellow represents children, the gray represents adults, and as you can see, 43% are disabled, and 23% are people over a certain age. And what's interesting is that if you look at the people spending the most on Medicaid, it is children. And so, I think you often, if you're someone, who votes and you're thinking about, what the candidates are saying about Medicaid, you should really think that a lot of the people that use Medicaid are children, and that it pays for the children's health insurance in this country. So next we'll look at the number and percentage of Americans under age 65 by source of insurance, and we'll look at the military. So the military does have its own health insurance plan. There are two plans. There's TRICARE and CHAMP-VA, or CHAMP-VA. TRICARE is for military retirees and dependents of active duty, retired, and deceased service members. And then you have CHAMP-VA, which is the Civilian Health and Medical Program of the VA. And this usually covers disabled, dependents, and certain survivors of veterans. So generally, TRICARE are people who retire from the from the military. So it wasn't just an honorable discharge, but they retired and usually spent their entire career there, or they're still in the military. Versus the CHAMP-VA is for survivors who got out and are disabled from their time in duty. And it's really important that everybody understand a big part of the Veterans Health Administration in this country, the VA system as it's often called, is that just because you did a tour, you served in our military, or let's say you did tours in Iraq, or fought overseas, does not make you eligible to use the VA system in our country. So what ends up happening is that you have to generally, in order to have access to the VA hospitals and the VA health system, you generally have to have some sort of disability. There's actually this really complicated calculation that I'm doing a really bad job explaining, but it's a combination of the number of years that you served, your current income, and the amount of disability that you have. And that tells you how long you have access to the VA and the extent of the coverage that they can offer you through the VA. It's really complicated, and so it's extremely important that everyone understand that not every veteran has access to the VA health system in this country, and with the way it's currently set up. Next, let's talk about the uninsured. So the uninsured in this country, in 2011 we had 18% of this country was uninsured, or 47.9%. Um, so if you look at the percentage of non-elderly uninsured by age in 2011, in total, 19.6% of all women were uninsured and 23.1% were men. Now, interestingly enough, the largest group of the uninsured, which I think is really a big problem, is the 21 to 24 and 25 to 34 population. And this is a problem because these are the people that we need wanting to buy health insurance. And I say this because, um, as it's almost like with health insurance, the way that I think about it is, okay, I'm young, I don't use health insurance that much, but I'm paying into it now so that in 20 years when I am sick and I do need it, I will have paid into it enough, and then I won't feel guilty about using it. Um, and some people may disagree with that concept, but essentially, when we have all these 21 to 24 year olds and 25 to 34-year-old age groups that aren't using health insurance and aren't enrolled, you know, they're the underutilizers that you need in paying premiums, because they don't generally have a lot of health expenses, and so they help keep the premiums down for everyone. And so by not having them, you know, because these people don't buy these, generally, I think what they found through research is that these populations often don't value health insurance. They don't think they're going to need it. Um, Generally, if they do need it, it is something huge, which is a big, very sad. They're in a car accident and it's a very expensive, medical event. Um, but, they are often, the risk of that happening is very low. And so in their mind, they are willing to take the risk. But I think it really has big impacts overall on the entire system, again, because, you need those people to buy into, you know, into the into the system, or buy insurance to help keep the cost down for everybody else, because again, they don't utilize health insurance a lot. Exhibit is the percentage of non-elderly Americans without health insurance, by race and ethnicity. So as you can see, Hispanics in 2011, 31.6% had no form of health insurance. So they're definitely the least, um, are the largest population without insurance, followed by the African American, which has 21%, um, the African American population, and then all the other ethnicities at 17.9. But in total, 18% are without insurance. What do we know about insurance and citizenship? So, Froston reported that 46% of all of non-citizens lack health insurance in 2011, versus, compared to 23.4 of naturalized citizens lacked coverage, and 15.2 of native citizens lacked coverage. So, our insurance problem, our uninsured problem, um, can be linked back in somewhat case to, you know, the citizenship issue. And the Pew Hispanic Center estimated that of the 11.9 million legal residents living in the United States in 2007, 6.8 million, or 81%, were uninsured. And this is based on the CPS estimates of the number of uninsured. Overall, this implies that about 15% of the insured in 2007 were illegals, um, which is a lot. Know about the Great Recession. Um, so, based on the National Bureau of Economic Research, they define the recession as beginning in December 2007 and ending in June 2009. And so there was a paper that looked at the data to understand the effects of the recession and what it had on coverage. And what they found was that approximately 9.3 million people lost coverage during that time. Um, and that this is large in part due to people losing their jobs. So, like I mentioned earlier, we have a program, or we have in this country a situation where, most people, a large percentage of the population receive health insurance through their employer. And um, when they lose their jobs, they often lose health insurance coverage. And during the recession, a lot of people lost their jobs. And so, in effect, this 9.3 million people losing coverage is not surprising. They didn't find an impact on the recession between women and children, and the impact was bigger on men and older workers and whites, but it really went across different educational categories. So it wasn't as if only high school educated were impacted more through the recession on regarding insurance. It was across all education levels. So with this, that concludes the end of this slide deck. Not a super long lecture. Make sure if you're uncomfortable with any of this stuff that you watch it. Watch the lecture again. I try to keep my lectures, not super long so that you guys have time to rewatch the lecture or email me if you have questions or call in during office hours. Um, and, I think it is safe to say that anything within this slide deck that I talked about is fair game. I think it's extremely important that you guys understand health insurance. It's the main source of revenue within our country, and so it's important to understand kind of the basics of it, which we just went over. And with that, have a good one. Bye.